Usually when we talk about a medical diagnosis, there's this expectation of absolute precision.
Right, like it's almost mathematical.
Exactly. Almost like engineering. Like
Mm.
if you break your arm, the x-ray shows that jagged white line on a black background, and the doctor just points at it and says, there it is.
Yeah, it feels very binary. Like it's either broken or it's not broken.
Right. It's clean. And as a patient, or even as a medical student, that clarity is really comforting. I mean, we like things to be visible. We like them neatly categorized.
But the reality is that clinical medicine rarely fits into those perfect little boxes.
And then, you step into the world of the operating room, and suddenly that neat, clean x-ray machine is, well, effectively broken. We're looking at a diagnostic and decision-making landscape that is, honestly, incredibly murky.
Oh, absolutely.
Because when you are standing over a patient with a scalpel, the ethically, quote-unquote, right choice isn't always highlighted on a glowing monitor. So, welcome to today's deep dive.
We're so glad you're here.
Yeah, if you are a medical student, a young professional navigating the healthcare field, or honestly just a deeply curious self-taught learner, you are in exactly the right place. Today, we are taking a really comprehensive educational look into a truly foundational textbook. It's called The Ethics of Surgery: Conflicts and Controversies, edited by Dr. Robert M. Sade.
It really is an indispensable text. Our mission today is to take the dense, sometimes abstract medical ethical frameworks found in this book and translate them into clear, practical applications for your future or perhaps your current medical career.
Right, and we want to do that without flattening the material, right?
Yeah.
Like without omitting the critical nuances that make these situations so famously difficult to navigate in the real world.
Exactly. We are covering a tremendous amount of ground today. We'll explore the so-called ethics gap in surgery and the really intense, very real clash between a patient's autonomy and a surgeon's fundamental duty to heal.
Yeah, and we will also dig into the heavy burden of professional integrity, which includes, the terrifying reality of disclosing surgical errors to a patient's family.
And finally, we'll look at the massive systemic pressures of surgical innovation, economics, and industry conflicts.
Okay, let's unpack this right from the start. I mean, why does surgical ethics even require its own dedicated textbook in the first place?
That's the perfect question to start with.
Right, like, shouldn't this just fall under the umbrella of general medical ethics? What makes a surgeon so different from a general practitioner when it comes to morality?
Well, you would certainly think the ethical rules apply equally across the board. But surgical ethics operates in a fundamentally different reality from the ethics of internal medicine.
Huh.
And understanding why it is so different provides the exact lens through which you, as a learner, need to analyze every single case study we are about to discuss today.
So where does that difference come from?
So the book details this fascinating study from the 1990s that first revealed what researchers termed an ethics gap. They looked at major medical and surgical journals and found that internal medicine journals contained over 4 times the frequency of ethics discussions compared to surgical journals.
Wait, 4 times? That is a massive disparity. I mean, did the researchers figure out why surgeons weren't talking about this stuff?
They actually conducted a follow-up survey at an academic medical center to try and answer exactly that. So they gave faculty members across different specialties a series of clinical vignettes regarding surrogate decision-making.
Okay, like what kind of vignettes?
For example, deciding the care path for a severely brain-injured young woman versus deciding the care for a newborn infant with Down syndrome and a severe heart defect.
Wow, heavy stuff.
Very. And what they found was fascinating. Surgeons responded to the survey at very high rates, which proved they actually cared deeply about the topics, but they disagreed with each other on the ethically acceptable options just as much as the other specialties did.
So if they cared and they engaged with the material, why the gap in the literature? Are we just saying surgeons don't talk about ethics because they are, doers rather than thinkers? It almost sounds like the difference between an automotive engineer who endlessly debates a car's aerodynamic design in a boardroom versus the mechanic who just has to fix the engine right now because it's smoking and the customer needs to drive home.
I love that. That analogy captures the urgency perfectly. The gap wasn't because surgeons lacked ethical principles. It was because the unique nature of surgery creates an entirely different operating environment that, well, it defies easy academic categorization.
So it's the environment itself.
Exactly. The book outlines several distinct ways surgery sets itself apart. First is the sheer magnitude of vulnerability and trust. A surgical patient is physically invaded, deeply anesthetized, and largely unconscious.
Right. They can't advocate for themselves at all in that moment.
Precisely. They are rendered entirely dependent on the surgeon's integrity. You physically cannot get more vulnerable than that.
That makes a lot of sense. The power dynamic in an operating room is just absolute.
It is. And second is the element of uncertainty and time. Surgeons face rapid, high-stakes decision-making. They frequently have to weigh a lack of complete information against the immediate urgency of a life-or-death intervention.
Right, like the internist has days to wait for a complex panel of lab results to come back.
Yeah.
But the surgeon might have, what, seconds to make a call before a patient bleeds out on the table?
Exactly. The third difference is the evaluation of skill. So cognitive competence, what a doctor knows in their head, is tested extensively through standardized board exams.
Right, multiple choice questions.
But manual dexterity, how well your hands actually move, the tactile feedback of tissue is highly subjective to evaluate. It's also something that changes, especially as a surgeon ages.
Yeah, how do you even put that into a textbook? I mean, you can't read a chapter on having steady hands.
You really can't, and that leads to the fourth major difference, which is research limitations. What's fascinating here is that the randomized controlled trial, the absolute gold standard of medical research for proving if something works, is incredibly difficult to execute in surgery.
Oh, because you can't easily give a patient a placebo surgery.
Precisely. Ethically, sham surgeries are an absolute minefield. Furthermore, you cannot double-blind a surgeon to the procedure they are performing. They literally have their hands in it.
Yeah, they know what they're doing.
Plus, surgical operations are what the book calls moving targets. Surgeons constantly make incremental technical adjustments during a procedure to suit the highly specific individual anatomy of the patient on the table. So if every surgery is slightly different, true scientific standardization is nearly impossible.
Okay, so if we establish that surgery requires this immediate, decisive action in a landscape of really high uncertainty, it seems inevitable that the surgeon's intense drive to fix the problem, what ethicists call beneficence, is going to collide violently with a patient's right to refuse care, which is their autonomy.
That collision is one of the most stressful experiences a clinician can face. We call it the tension between the action and the choice.
I really want to explore what happens when patients refuse care in life or death emergencies. I mean, it's one thing to politely decline a cholesterol medication in a clinic, but what happens in the extreme environment of the OR?
The textbook offers a classic, highly illustrative scenario for this, which is the Jehovah's Witness dilemma.
Oh, wow, okay.
Yeah. Imagine a surgeon is performing a routine, generally safe operation on a patient who is a Jehovah's Witness. Suddenly, a rare catastrophic complication occurs, and the patient begins exsanguinating bleeding to death right there on the operating table.
That is a nightmare scenario.
It is. The surgeon has been conditioned through years of brutal residency to turn death aside. They know they can save this patient instantly with a simple blood transfusion, but they have the patient's strict advance directive clearly forbidding blood transfusions due to her religious beliefs.
I have to admit, I struggle with this one. I mean, if I have the power to stop the bleeding and the blood is sitting right there in a cooler and I just stand back and watch someone die,
Yeah.
how is that ethical? Doesn't the instinct to save a life trump a piece of paper?
It's a scenario that causes immense moral distress for medical teams. The psychological toll of standing down while a patient dies is profound. But the standard ethical consensus, which is firmly backed by decades of legal precedent, is that a competent patient's first-person advance directive simply cannot be overridden.
So autonomy wins out.
Yes. The principle of respect for autonomy, the right to control what happens to your own body, takes absolute precedence over the surgeon's beneficence. But the source material introduces a vital, proactive concept here for your daily practice, which is called preventive ethics.
Preventive ethics, meaning, you don't wait for the bleeding to start to figure out your ethical stance.
Precisely. Preventive ethics dictates that the surgeon should have explored these deep value conflicts and developed a comprehensive management plan before the procedure ever started.
Like having a really thorough conversation beforehand.
Exactly. Did the surgeon ensure the patient's refusal wasn't clouded by extreme anxiety or coercion from their community? Did they sit down in the preoperative consultation and thoroughly discuss all alternative blood conservation strategies like cell salvage or hemodilution?
Ah, I see.
The ethical failure in this scenario wasn't necessarily just on the operating table. The failure was upstream in the consultation room.
That shifts the burden of ethical care far upstream, making it a required part of the medical prep. It's a great lesson. But let's look at autonomy versus beneficence from another angle. What happens when the patient isn't just refusing care, but actively destroying the care you provide?
Oh, the non-compliant patient.
Yeah, like if a patient is completely non-compliant, at what point does the surgeon's obligation end?
The book tackles this beautifully through the case of a patient we'll call Mr. Smith. He is an intravenous drug user. Through his drug use, he gets a severe infection and destroys his native biological aortic valve in his heart. The surgical team goes in, performs a massive open heart surgery, and gives him a brand new prosthetic valve to save his life. But then he goes back out, continues his intravenous drug use, and completely destroys the new prosthetic valve through recurrent infection. Now he's back in the ER, dying again.
See, here's where I want to push back.
Yeah.
Because if a patient keeps systematically destroying the expensive life-saving hardware I just installed, aren't I just enabling their addiction by fixing it again?
It's a very tough situation.
Right. And if we look at the utilitarian idea of, the greatest good for the greatest number, shouldn't I save those incredibly expensive hospital resources, the hundreds of thousands of dollars, the ICU beds, my team's time for a patient who will actually take care of themselves?
That is a very common, very human reaction. You are essentially calculating the return on investment for the healthcare system. But the analysis in the book dismantles this utilitarian argument using a thought exercise called the comparison test.
The comparison test.
Yeah.
Okay, how does that work?
I want you to imagine a parallel case. You have a young mother with systemic lupus who requires heavy immunosuppression medication. Through no fault of her own, because her immune system is weakened, she innocently develops a valve infection.
Okay, I follow the parallel.
She comes into the ER, and statistically, she has the exact same reduced life expectancy and poor survival odds as the intravenous drug user. Would you operate on the mother with lupus, knowing her long-term odds are terrible?
Well, yes, absolutely, without hesitation. I mean, it's not her fault.
Then you must operate on the drug user. The textbook argues that to do otherwise is to make moral prejudgments based on a subjective concept of social worth.
Wow. Okay, yeah.
If you operate on one but not the other, you aren't making a medical decision based on survivability. You are deciding who deserves to live based on your judgment of their lifestyle choices. And acting as a judge of character is a direct violation of the core tenets of the AMA Code of Medical Ethics.
That makes total sense when you frame it like that.
Right. A surgeon's primary overarching duty is to the sick patient directly in front of them, not to act as an agent of societal judgment.
Wow. That is a stark, powerful reality check for clinical bias. It's so easy to disguise a moral judgment as a medical resource calculation. And I think that perfectly bridges us into the next major concept, which is professional integrity and the burden of truth.
Yes, this is a heavy one.
Because if maintaining ethical clarity is difficult when the patient acts non-compliantly, what happens when the moral failure comes from the system? Or worse, from the surgeon themselves? The pressure to bend the rules must be immense.
It is, and the textbook illustrates this pressure through a very common, highly relatable scenario for young professionals, which is deceiving insurance companies. Or, as it is politely called in the hospital corridors, miscoding.
Yes. Oh, I've heard so much about this. You have a patient who desperately needs a specific procedure, but the insurance company denies coverage based on strict, sometimes completely arbitrary bureaucratic criteria. So the surgeon realizes that if they just tweak the diagnostic code on the paperwork, like a little white lie, the insurance company's algorithm will approve it, it will pay out, and the patient gets the life-saving care they need.
It seems like a victimless crime, right? The book analyzes this dilemma through the lens of ancient philosophy, which is actually quite revealing. The Greek philosopher Plato might actually justify this deception.
Really? Plato would be pro-miscoding?
Well, he argued in his writings for the concept of the noble lie, the idea that deception by a leader could be acceptable if it ultimately results in a greater benefit for the people they serve. A surgeon could use Plato to argue they are lying for the patient's ultimate good.
But I'm guessing the textbook leans heavily on Aristotle to counter that justification, doesn't it?
Yes, it does. Aristotle's Nicomachean Ethics focuses on habituation and virtue. Aristotle would argue that lying, even for a seemingly good cause, fundamentally undermines the physician's character.
So it's about what it does to the doctor over time.
Precisely. Every time you lie, you carve a deeper groove into your habits, degrading your professional integrity long term. And from a modern medical ethical standpoint, miscoding violates the principle of justice. It is arbitrary. It only benefits the specific patients that the surgeon happens to like or advocate for.
Right. Not everyone gets the benefit of a white lie.
Exactly. Furthermore, gaming the system does absolutely nothing to fix the underlying flawed healthcare system. It merely perpetuates a culture of deception.
Which brings us to perhaps the hardest truth of all for a medical professional, which is disclosing medical errors. The text references the landmark Institute of Medicine report, To Err is Human, which really brought the sheer volume of medical mistakes into the public consciousness.
The book provides a harrowing case study for this. Let's look at the case of a surgeon we'll call Dr. Waffle.
Okay.
During an intended routine removal of a lung lobe, he accidentally ligates, or completely ties off, a vital branch of the pulmonary artery. This massive technical mistake forces him to perform a complete pneumonectomy, meaning the removal of the entire lung, to stop the bleeding.
Oh, no.
Tragically, the patient's body cannot handle the stress, and the patient dies as a result.
Wait, realistically, though, if I'm a young surgeon, my career is on the line, the hospital's legal team is breathing down my neck, and the patient has already passed away. Isn't the pressure to just stay quiet completely overwhelming?
It is incredibly overwhelming.
I mean, if the patient is already dead, who does the disclosure help? Doesn't it just invite a massive malpractice lawsuit, destroy the surgeon's life, and bring the grieving family even more pain?
What you are articulating is the classic consequentialist argument. A consequentialist ethicist weighs the ultimate outcomes. They look at the immense emotional and financial harm to the surgeon's career, the potential lack of closure for the family if they engage in a 10-year legal battle, and they might actually argue that non-disclosure minimizes overall pain in the world.
But I'm guessing the textbook doesn't side with the consequentialists here.
It does not. The deontological argument, which is based on strict, rule-based duty, wins out completely. The consensus of the medical community is that the physician's paramount responsibility is to the patient and their family.
So the rules are the rules.
Yes. Honesty and truth-telling are non-negotiable fundamental duties of the profession. The surgeon must find the moral courage to disclose the error honestly, explain exactly what happened in clear terms, and apologize.
That is heavy. But let me ask you a harder question. What if it's not your error? What if you are looking at another doctor's work?
The textbook covers this too. Imagine you are Dr. Jones, and you are reviewing a patient's medical file. You discover that another surgeon, Dr. Lapps, completely skipped a crucial biopsy step years ago, which ultimately resulted in the patient having their lung removed completely unnecessarily.
Wow.
Do you tell the patient about Dr. Lapp's devastating mistake?
That is an absolute professional minefield. I mean, you are opening up a colleague to a massive lawsuit, and you might have to work with this person every single day.
It's true. But if we connect this back to the bigger picture, the medical community's mandate is to explore, do not ignore.
Explore, do not ignore.
Yes, a surgeon must first gather all the actual facts before speculating. You absolutely cannot just throw a colleague under the bus based on a hunch or an incomplete chart. But ultimately, if the error is verified, the AMA code and the ethical consensus dictate that the patient has an absolute, undeniable right to understand their own disease state.
Meaning they need to know why they are in the condition they're in.
Exactly. And that includes understanding how their past care directly affected their current physical condition. Your fidelity is always to the patient, not to the protection of the medical guild or your colleague's ego.
It requires an immense amount of moral courage to walk into that patient's room. Okay, for our final topic today, we are going to zoom out entirely. We've looked at the surgeon's integrity in the OR and the consultation room. Now let's look at the macro forces.
Right, systemic pressures, economics, and industry.
Yes. How does the sheer cost of healthcare warp these ethical decisions? I have to imagine financial desperation forces surgeons into some really uncomfortable corners.
Absolutely. Financial realities often crash right into clinical judgment. The book highlights a perfect example of this. You have a 22-year-old college student with Marfan syndrome, which is a connective tissue disorder.
Okay, got it.
He has a slowly expanding aorta. Now, standard, rigorous medical guidelines say the aorta isn't large enough yet. It's not quite time to operate. But he is about to graduate college and lose his father's excellent, comprehensive health insurance.
Oh, I see where this is going.
He begs the surgeon to perform the complex, incredibly expensive open-heart surgery now while it's fully covered, rather than waiting a year and risking total bankruptcy.
This is where we have to balance the different ethical pillars, right? Because on one hand, you want to help the guy.
Yes. This is a brilliant test of what ethicists call the Georgetown mantra, which consists of 4 core principles: autonomy, beneficence, non-maleficence, and justice. The patient is aggressively exercising his autonomy by requesting the surgery to protect his financial future. but the surgeon must weigh that against non-maleficence.
Which is the strict duty to do no harm. Because performing a major open-heart surgery that isn't medically necessary introduces massive, unjustified physical risk to the patient.
Exactly. Even in the absolute best hands, an aortic repair carries a real risk of mortality, stroke, or permanent disability. Operating before it is strictly medically indicated clearly violates non-maleficence.
It's just too dangerous.
Furthermore, it violates the principle of distributive justice. You would be utilizing incredibly scarce, expensive healthcare resources, operating room time, limited blood products, ICU beds for a procedure that isn't currently needed, simply to solve a patient's financial problems.
So the system can't support that kind of decision.
Right. The resounding medical consensus in the text is that an impending loss of health insurance is never a valid medical indication for complex surgery.
That's a tough conversation to have with the patient. Let's pivot from economics to the pressure of innovation, because it isn't just patients feeling the pressure. Doctors feel it too. What happens when a surgeon feels they are falling behind the times?
The text provides a great case study of a 55-year-old traditional open surgery doctor who sees his younger, newly hired partner attracting huge volumes of patients by utilizing a highly marketed, new robotic surgery system.
Like the Da Vinci systems and things like that.
Exactly. The older surgeon decides he needs to learn the robotic technique immediately, primarily to keep his private practice competitive and protect his income.
I'm going to play devil's advocate here. Isn't that just healthy capitalism? Why is a doctor's self-interest a bad thing if it pushes them to learn a new skill and the patient ultimately gets a successful, minimally invasive surgery?
It raises a vital question about a doctor's internal motivation versus the clinical outcome. The American College of Surgeons has a guiding motto, omnibus per artem fidemque prodesse, which means to serve all with skill and fidelity. While self-interest and market competition are totally normal human drives, medical decisions must prioritize the patient's absolute safety above all else.
So the book isn't saying he can't learn the robot, but it's dictating how he must learn it.
Precisely. Robotic surgery involves an incredibly steep learning curve. The ethical adoption of any new technology requires rigorous institutional review boards, highly specialized offline training, and strict proctoring by recognized experts until surgical competence is objectively proven.
You can't just wing it.
No, you cannot. It cannot be adopted hastily purely out of market jealousy without safeguards, because if you do that, the patient simply becomes an unwitting practice dummy for a surgeon trying to protect his market share.
That concept of protecting one's income ties directly into our last major topic, conflicts of interest, or COI, specifically regarding the pharmaceutical and medical device industries.
This is a huge area of ethical concern.
Right. And the book talks about how even something as small as a pharmaceutical rep giving a doctor a branded pen or paying for a free pizza lunch for the clinic can be ethically problematic. Is it really that serious? I mean, it's just a pen.
It seems trivial on the surface, but behavioral social science research is incredibly clear on this. Even tiny gifts trigger a powerful, deeply unconscious human impulse for reciprocity.
The idea being, you give me a free pen and I unconsciously want to prescribe your specific blood pressure drug to kind of balance the social ledger.
Exactly. And we must impartially acknowledge that close collaborations between physicians and private industry have driven massive, life-saving medical advancements over the decades.
Oh, for sure.
Things like transcatheter heart valves and complex left ventricular assist devices, or LVADs, only exist because doctors and engineers work together. However, the financial ties inherent in these relationships are fraught with peril.
Because the primary interest of the physician, which must always be the patient's health, can be subtly corrupted by the secondary interest of personal financial gain, consulting fees, or securing research funding.
Which is exactly why the ethical standard today demands strict, absolute transparency and public disclosure of these financial relationships. Patients can be seriously harmed when physicians make substandard choices, like implanting a specific brand of joint replacement that might not be the absolute best anatomical fit for the patient, simply because they are under the sway of unconscious bias from a lucrative consulting fee or a free luxury dinner.
Okay, we have covered a massive amount of incredibly nuanced material from Dr. Seed's textbook today. We've gone from the ethics gap to the Georgetown mantra, from Aristotle's series on lying to the psychological weight of medical errors.
It's a lot to take in.
It really is. So what does this all mean for you, the learner listening right now? The core takeaway here is that surgical ethics and medical ethics at large is not about achieving absolute robotic perfection.
Not at all.
It is about maintaining rigorous cognitive and technical competence. uncompromising personal integrity, and relentlessly prioritizing your patient's best interests amidst the absolute chaos of clinical uncertainty, high-tech innovation, and massive systemic pressures. It means your clinical judgment must be as sharp ethically as it is medically.
And to reinforce what we've covered today, as an educational exercise, I have a review question for you to consider.
Oh, perfect. Let's hear it.
Based on our deep dive, what exactly is preventive ethics, and how specifically could it have been utilized to resolve the intense dilemma of the bleeding Jehovah's Witness before she ever reached the operating table? Think deeply through the steps of preoperative communication and early value exploration.
It's a fantastic mental exercise to prep for those tough, inevitable conversations you will have in your career.
And as we wrap up our analysis of the text, I want to leave you with one final provocative thought to ponder. Consider the rapid, unstoppable advancement of technology we discussed today. As artificial intelligence and advanced robotic systems eventually take over more and more of the actual manual dexterity and real-time decision-making of surgery, will the profound ethical burden of the operating room begin to shift away from the surgeon's physical hands and onto the hospital's software programmers? Will the algorithms of the future carry the ultimate burden of beneficence?
Wow. When the X-ray machine of surgical ethics gets an AI upgrade, does the water finally get clearer, or does it just get murky in an entirely new, unprecedented way? It's something to deeply consider as you step into the future of medicine. Keep learning, keep analyzing, and keep asking the hard questions.